The anatomy of the lumbar medial branches of the dorsal rami. Relevance to image-guided radiofrequency ablation for osteoarthritic-related low back pain. Authored by John Tran, Ann Agur, and Eldon. Learning objectives. With active participation, audience member will be able to 1. Illustrate the detailed spatial relationship of the lumbar medial branches to relevant bony landmarks and soft tissue landmarks. 2. Describe the importance of detailed anatomical relationship on optimizing image-guided lumbar radiofrequency ablation for the treatment of osteoarthritic low back pain. And 3. Discuss the implications of the current anatomical findings on standard treatment protocol for lumbar radiofrequency ablation. Introduction. Chronic facet low back pain due to osteoarthritis is a very common condition that impacts a large patient population. The resulting pain substantially impairs the individual's mobility, activity level, and quality of life. This results in significant economic and healthcare burdens. Image-guided radiofrequency ablation is a viable treatment option for facet low back pain. This treatment involves the use of fluoroscopy to guide the placement of electrodes into a patient's body, targeting the sensory nerve known as lumbar medial branches, which transmit pain signals to the brain. A current is passed through the needle to apply thermal heat on the medial branches to stop them from functioning. This procedure can provide relief from chronic debilitating pain, which ultimately restores mobility and activity in patients suffering from chronic facet low back pain. The success of lumbar radiofrequency ablation requires detailed understanding of human anatomy. Physicians need to know where the nerve is in relation to the bony and soft tissue landmarks to be able to use fluoroscopy to guide placement of the electrode to the targeted nerves, as the sensory nerves cannot be seen with current imaging technologies. Furthermore, to optimize duration and effect, the electrode needs to be placed parallel and next to the medial branch, which once again depends on the detailed understanding of the anatomical relationships. However, there is currently a lack of in-depth understanding of the anatomy of the lumbar medial branches, limiting the ability of physicians to accurately target the nerve, thereby impacting procedural effectiveness. Therefore, the objective of this study was to investigate the relationship of medial branches to anatomical landmarks and discuss the implications for lumbar facet joint denervation. To accomplish this, we performed meticulous cadaveric dissection in 10 low back specimens. The lumbar medial branches from the 1st to 5th lumbar levels were exposed, and its origin, course, and relationship to bony and soft tissue landmarks were documented. In doing so, we found that the L1 to L5 medial branches consistently course in the same path at each level. Each medial branch, highlighted by the green colored sutures in the schematic diagram and dissection picture shown here, was found to course on the lateral neck of the superior articular process, highlighted by the number 1. The nerve continued posteriorly until it dove deep to the musculo-ligamentous structure that consists of the mammallo-accessory ligament, highlighted by the yellow arrow, tendon of the erector spinae, black arrow, and the muscle known as the intertransversalis medialis, highlighted by the red arrow. It was also noted that the direction of the medial branch changes as it coursed along the lateral neck of the superior articular process. On the more anterior half, the nerve was coursed in a more lateral trajectory, but on the posterior half, it coursed in a more parasagittal and medial trajectory. This observation is important as it has implications for the traditional approach to targeting the medial branch. Based on our findings, the traditional approach, highlighted by the red arrow or line, could be adjusted to have a more parasagittal and caudal orientation, shown by the green line, which could actually achieve a more parallel alignment with the targeted medial branch. These adjustments could potentially lead to greater nerve capture rates, leading to better pain relief outcomes. In conclusion, the results of the lumbar medial branches to anatomical landmarks is essential to optimizing needle placement for denervation procedures. Our findings suggest a parasagittal placement with greater caudal angulation may improve parallel tip alignment to the targeted medial branch. The potentially more effective lumbar denervation procedures based on detailed anatomical research may lead to better management of chronic facet low back pain and improve patient mobility and activity levels. Acknowledgements. The authors would like to thank the individuals who donated their bodies and tissue for the advancement of education and research, as well as Parkwood Institute Research Specific Endowment, the Mary Elizabeth Horney Fellowship in Rehabilitation, providing funding to support this research. Thank you.